Okay, so today we're going to take a deep dive into something super important for all you nephrologists out there, managing ADPKD, and how you can make sure your patients get the absolute best possible care.
Sounds good.
We're going to really unpack these brand new KDIGO 2025 ADPKD guidelines and pull out the key recommendations, all the practical insights that you can actually take straight from this deep dive and apply in your practice.
Yeah, that's exactly it.
Without kind of getting bogged down in the super nitty-gritty details.
Yeah.
We want to make this really clear and really useful for you.
Absolutely.
So I guess let's just jump right in then. Obviously, this condition, ADPKD, it's marked by the development of these kidney cysts and requires, a really considered and consistent approach to management.
Yeah.
To make sure we're giving our patients the best chance at a good outcome.
Exactly.
So let's start right at the beginning, with diagnosis and assessment.
Okay.
So if you're a nephrologist, what should your kind of first-line imaging strategy be?
So the guidelines are very clear that ultrasound is the initial imaging modality of choice for diagnosing ADPKD.
Okay.
And why is that? Well, it's inexpensive, it's portable, and it's widely available.
Yeah.
So it makes it a really practical first step for many patients.
It makes perfect sense. Yeah.
Yes.
Something that's safe and readily available.
Exactly.
But we know ultrasound, it's got its limitations.
Yeah.
Right?
Of course.
Particularly in certain situations.
Exactly. So ultrasound isn't that great at detecting very small cysts. And that's especially true in individuals under 30.
Right.
And also in potential kidney donors as well.
Okay.
So if those initial ultrasound results are equivocal, especially in younger adults, then MRI is recommended.
Gotcha.
And that's because it's got superior sensitivity for those really small cysts, so down to 2 millimeters, and it's also got much better soft tissue contrast, so you can really get a good, clear answer.
Okay. And then where does CT kind of fit into this whole diagnostic process?
Yeah, so CT with contrast, that becomes really valuable when there's a clinical suspicion of other issues alongside ADPKD.
Okay.
So, things like kidney stones, masses, hemorrhage, hydronephrosis.
Right.
It's also got excellent sensitivity for small cysts as well,
Okay.
down to 2 millimeters. But importantly, the guidelines also remind us to always factor in the availability and cost of these different imaging tools, because it can vary quite a bit depending on the healthcare setting.
Yeah, that's a really good point about being, resource conscious.
Yeah.
Okay, so moving on then to genetic testing.
Okay.
I feel like this is an area that's constantly evolving in kidney disease management.
Yeah.
So what's the role of genetics in these new ADPKD guidelines?
Yeah, so genetic testing definitely has its place, and the guidelines suggest that it can be particularly helpful in families where ADPKD presents very differently among members, so what we call marked phenotypic variability.
Okay.
Or in cases where very early onset ADPKD is suspected, or if we think a new mutation might have occurred.
So not necessarily a routine test for every patient you see with suspected ADPKD?
No, not a universal first-line diagnostic tool.
Okay.
But it is vital to remember that some of the genes involved in ADPKD are also associated with recessive conditions.
Okay.
So if you identify a pathogenic variant in a patient, it's really crucial to offer counseling about potential risks for their children.
Right.
And carrier testing for partners should be considered if they're planning a family.
That's really important for family planning and genetic counseling and that sort of thing.
Absolutely.
And I know the genetics of ADPKD, especially the PKD1 gene, can be quite complex.
Yeah.
Have the testing methods that you use in your practice changed much over recent years?
Yeah, they have evolved significantly.
Yeah.
We've moved from Sanger sequencing, which was a more traditional method for looking at the PKD1 gene, to much more efficient techniques like targeted next-generation sequencing, or TNGS, and whole exome sequencing, or WES. So think of it this way. Sanger was like reading one page of the genetic code at a time, whereas NGS allows us to scan the whole book much faster and more cost-effectively.
Okay.
But it is really important to keep in mind that even with these advancements, clinical genetic testing doesn't catch every single pathogenic variant. The detection rate is around 75%. So a negative genetic test doesn't entirely rule out ADPKD in the right clinical context.
Okay, that's a good practical point to remember.
Yeah.
The guidelines also mentioned the value of a multidisciplinary team approach in certain situations.
Yes.
So when should you, as a nephrologist, consider bringing in other specialists for diagnosis?
So for those more challenging diagnostic cases,
Okay.
bringing together a nephrologist, genetic counselor, medical geneticist, and radiologist can be incredibly valuable.
Makes sense.
And that's because their combined expertise allows for comprehensive counseling, accurate interpretation of complex genetic findings, and the best approach to follow-up imaging surveillance.
Yeah, I mean, that collaborative approach makes total sense.
Yeah.
Especially for those, trickier cases.
Definitely.
Okay, so let's move on then to predicting how the disease might progress in your patients.
Okay.
What factors are now considered to be kind of the most important early indicators of disease trajectory?
So the guideline really emphasizes height-adjusted total kidney volume,
Okay.
or HTTKV.
Okay.
So essentially how large the kidneys are relative to the patient's height
Right.
as the best early biomarker.
Right.
And this is where the Mayo Imaging Classification, or MIC, comes in.
Right.
It's a system that uses MRI-measured kidney size and the patient's age to help us predict who might have a more rapidly progressing form of ADPKD.
So essentially, the size of the kidneys early on is a really key piece of the puzzle.
It is, but it's not the only one.
Right.
So you also want to continue to monitor kidney function,
Okay.
specifically the eGFR in relation to the patient's age.
Yeah.
And the rate at which the eGFR is declining over time.
Mm.
Early onset of hypertension and urological events like kidney stones or infections also carry prognostic significance.
Oh.
The PRO-PKV score,
Right.
which incorporates genetic and sex data along with early symptoms, is another tool that can provide you with prognostic insights.
So it sounds like quite a multifaceted assessment.
Yeah.
And just a quick reminder on the MIC.
Okay.
I recall there being some caveats about its use in all ADPKD patients.
That's correct, yeah. So the MIC was primarily developed and validated in individuals with either PKD1 or PKD2 mutations,
Okay.
or in those with typical ADPKD without specific genetic characterization.
Okay.
So applying it to predict prognosis in patients with ADPKD due to rarer gene mutations might not yield reliable results.
Right.
And it's also worth reiterating that disease severity tends to be more pronounced in individuals with PKD1 mutations compared to those with PKD2 mutations.
Okay, so that's a really helpful overview of diagnosis and how to kind of think about prognosis.
Yeah.
Let's move on now to blood pressure management.
Okay.
Which, as you know, is a cornerstone of care for your ADPKD patients.
Yeah.
So what's the first line recommendation in these new guidelines?
So the guideline strongly recommends using renin-angiotensin system inhibitors or RA.
Right.
So that's either an ACE inhibitor or an ARB as the first-line treatment for high blood pressure in your ADPKD patients.
Okay.
The goal is to achieve the recommended blood pressure target, and this carries a level 1C recommendation.
Okay, so that's a pretty firm recommendation.
Yeah.
And what's the main evidence supporting the use of RAS inhibitors as first line?
So the rationale is based on our understanding of the kidney and cardioprotective effects of RZ in chronic kidney disease in general.
Yeah.
While we don't have, massive randomized controlled trials exclusively in ADPKD,
Right.
the HLT-PKD-AUS study did demonstrate the safety and tolerability of ACE inhibitors in this specific patient population.
Right.
So the evidence, while perhaps not ADPKD exclusive for efficacy, strongly supports their use for blood pressure control and potential kidney protection.
Gotcha. And are there any specific combinations of blood pressure medications that you should be particularly careful to avoid in ADPKD?
Yeah, so the guideline explicitly advises against combining ACE inhibitors, ARBs, and direct renin inhibitors.
Okay.
This is a level 1B recommendation.
Right.
Additionally, if a patient's high blood pressure proves resistant,
Yeah.
so requiring 3 or more different medications to control, it's important to investigate for other underlying causes of hypertension beyond just the ADPKD itself.
Right.
And finally, if you see significant protein in the urine, so high-grade proteinuria,
Yeah.
that should prompt you to consider whether there might be a coexisting kidney disease.
Okay. So that's really practical guidance for
Yeah.
managing hypertension in this population.
Yeah.
Let's move on then to a symptom that significantly impacts so many ADPKD patients,
Right.
which is pain.
Yeah.
What are the kind of key things the new guidelines emphasize for pain management?
So one really important point is that the severity of chronic kidney pain in ADPKD often doesn't directly correlate with the overall kidney volume.
Okay.
You can have patients with even relatively smaller kidneys
Yeah.
experiencing significant and debilitating pain.
Yeah, and that must be so challenging for both the patient and for you as the treating physician.
Absolutely.
So what's the recommended approach to tackling this often complex pain?
So for chronic pain that doesn't respond to initial measures, a multidisciplinary team approach is strongly encouraged.
Okay.
This could involve specialists from nephrology, radiology for potential interventions, pain management specialists, so algologists, mental health professionals,
Right.
psychology or psychiatry physiotherapists, urologists, and even hepatologists if liver cysts are contributing to the pain.
Yeah.
This kind of holistic approach
Yeah.
recognizes the multifaceted nature of chronic pain in ADPKD.
Yeah, I mean, that collaborative model makes a lot of sense,
Yeah.
given the various potential sources of pain. What about specific treatment options that you should be considering?
So the guideline outlines a range of options, starting with simpler things like acetaminophen
Okay.
and application of heat or ice.
Yeah.
But for more persistent pain, they suggest considering nerve blocks, renal denervation procedures,
Okay.
and percutaneous techniques like cyst sclerotherapy or fenestration.
Right.
Importantly, the guideline also highlights the need to screen ADPKD patients with chronic pain for symptoms of depression,
Right.
as this can significantly influence their pain experience and overall management.
Yeah, that's a crucial reminder about the psychological aspect of chronic pain.
Yeah.
Okay, so let's talk about some common complications that you're likely to encounter in your ADPKD patients,
Okay.
which are kidney stones and gout.
Right.
So what does the guideline advise here?
So for kidney stones, the primary recommendation for all your ADPKD patients who are stone formers
Okay.
is to advise them to aim for a daily urine output of at least 2.5 liters.
Okay.
This is a level 2B recommendation. You should also counsel them on the potential links between stone formation and factors like obesity, diabetes, and metabolic syndrome,
Right.
as managing these can help reduce their future risk.
Makes sense.
A dietary assessment with a registered dietitian is also a valuable step to consider.
Okay. And is the medical treatment for kidney stones in ADPKD any different from the general population?
No, the medical treatment for recurrent kidney stones in your ADPKD patients should generally follow the same principles as for any other patient with kidney stones.
All right.
However, for those with a history of stones, 24-hour urine testing to identify specific risk factors for stone formation
Yeah.
and analysis of any past or retrieved stones are recommended to guide preventative strategies.
Gotcha. What about gout, which we know can sometimes be associated with kidney disease?
Yeah, so the guideline recommends that when you're evaluating and treating gout in your ADPKD patients,
Yeah.
you need to take their level of kidney function into account.
Okay.
They align with the 2020 guidelines from the American College of Rheumatology, with allopurinol being the preferred first-line medication for lowering uric acid levels.
Okay.
However, you'll need to adjust the starting dose and how quickly you increase the dose based on the patient's CKD stage.
Gotcha.
Typically starting with lower doses
Yep.
and increasing more gradually in those with more advanced kidney disease.
Okay, so clear guidance on managing these common comorbidities.
Yeah.
Let's move on to some other potential issues you might see,
Okay.
which are hematuria and kidney cyst infections.
Okay.
So hematuria or blood in the urine is quite common in ADPKD.
Yeah.
And often happens spontaneously.
Exactly.
You're more likely to see it in patients with larger kidneys, hypertension, and more advanced CKD.
Yeah.
Interestingly, experiencing gross hematuria at a younger age has been linked to faster overall disease progression.
Yeah.
And the guideline emphasizes the importance of providing clear guidance and reassurance to patients
Yeah.
when this occurs.
Absolutely. Yeah. I mean, that reassurance can be really important for alleviating patient anxiety.
For sure. Okay, so what about when there's evidence of an actual infection in a kidney cyst?
Yeah, so kidney cyst infection should be on your radar if your ADPKD patient presents with fever,
Yeah.
acute pain in the abdomen or flank,
Yeah.
and elevated white blood cell count and/or C-reactive protein.
Gotcha.
Lipid-soluble antibiotics such as fluoroquinolones or trimethoprim sulfamethoxazole are preferred
Okay.
for a treatment course of 4 to 6 weeks.
Right.
And that's because they can better penetrate the cyst.
Right.
In some cases, aspiration of the cyst might be considered to help with diagnosis.
Gotcha. Okay, so important for timely and effective treatment of these infections.
Exactly.
Now let's touch on the management of diabetes and cardiovascular disease
Okay.
in your ADPKD patients, as these are, significant health concerns for many with CKD.
Yeah. So the guideline states that the management of diabetes and ADPKD should generally follow the same principles as you would use in any other patient with CKD.
Okay.
However, there is a notable exception. SGLT2 inhibitors are not currently recommended for patients specifically, and that's due to a lack of safety data in this population.
Okay.
And a theoretical concern about potentially increasing vasopressin levels and promoting cyst growth.
Right.
You might only consider them if the patient also has heart failure.
So that's a really crucial distinction to be aware of.
Yeah.
What about primary prevention of cardiovascular disease in your ADPKD patients who don't yet have established CVD?
So for primary CVD prevention in adults with ADPKD who are not on dialysis or haven't had a kidney transplant, lipid-lowering therapy should be initiated according to the KDIGO guidelines for lipid management in CKD.
Okay.
This generally involves a more fixed dose strategy rather than strictly treating to a specific target LDL cholesterol level.
Makes sense to align with established CKD guidelines.
Yeah.
ADPKD specific data is limited.
Exactly.
Okay, so kidney transplantation is, of course, a critical consideration for patients with advanced ADPKD, of course. Yeah. So what are the kind of key recommendations regarding transplant for you to bear in mind?
So kidney transplantation is indeed the preferred treatment when your ADPKD patients reach kidney failure.
Right.
Living donor transplant generally offers better outcomes.
Okay.
With a lower risk of rejection and longer survival of the transplanted kidney.
Right.
Preemptive living donor transplant, meaning before the patient starts dialysis, is considered the optimal approach whenever feasible.
Okay. What about the practice of removing the patient's native heavily cystic kidneys before they receive a transplant? Is that a routine procedure?
So the guidelines suggest that removing the native kidneys before transplant should only be done for specific medical reasons where the benefits clearly outweigh the risks.
Okay.
It's crucial to have a thorough discussion with the patient.
Yeah.
Shared decision-making is key here and involve a multidisciplinary team when considering this. Interestingly, some data suggests that there might be an increased risk of in-hospital mortality if the native nephrectomy is performed before the transplant itself.
Well, that's an important point about the timing of a nephrectomy in relation to transplant.
Yeah.
What about the management of ADPKD patients after they've received a kidney transplant?
Okay.
Are there any specific considerations for them compared to other transplant recipients?
So generally the same immunosuppressive protocols are used as in other kidney transplant recipients. However, you should be aware that certain post-transplant complications seem to be more common in ADPKD patients.
Okay, such as?
Including a potential progression of existing valvular heart disease, the development of erythrocytosis or high red blood cell count, and new onset diabetes after transplantation. The guideline also recommends screening for renal cell carcinoma with an abdominal MRI within the year leading up to the transplant.
Okay, interesting. What about dialysis as a kidney replacement therapy option for your ADPKD patients who are approaching or have reached kidney failure?
So both peritoneal dialysis, or PD, and hemodialysis, or HD, are viable options for ADPKD patients with kidney failure.
Okay.
The choice should really be individualized, taking into account the patient's preferences, their lifestyle, and any other medical conditions they might have, such as hernias or diverticula, which could potentially favor one dialysis modality over the other.
Okay.
The guideline does note that we still need more research directly comparing the outcomes of PD versus HD, specifically in the ADPKD population.
Okay, let's turn our attention then to tolvaptan, which is a medication specifically approved for ADPKD in many parts of the world.
Yeah.
So what does the new KDIGO guidelines say about its use in your patients?
So the recommendation is to offer tolvaptan to adult patients with rapidly progressing ADPKD who have an eGFR between 25 and 65 milliliters per minute per 1.73 meters squared. This carries a level 1B strength of recommendation.
Okay, and what's the primary evidence and rationale behind that recommendation?
So the recommendation is based on evidence from clinical trials showing that tolvaptan can effectively slow down the progression of kidney disease in these patients, as demonstrated by a reduction in the rate of eGFR decline. It may also provide some benefit in reducing kidney pain and the frequency of urinary tract infections. The greatest benefit appears to be in individuals who are 55 years of age or younger and who have established or are at high risk of rapid disease progression based on those Mayo imaging classification subclasses 1C through 1E.
Okay, but I know there are some significant potential risks
Yes.
and monitoring requirements associated with tolvaptan.
Absolutely. Yeah. So the risk of drug-induced liver injury is a major consideration.
Okay.
And it necessitates mandatory monthly liver function testing for the first 18 months of treatment, followed by every 3 months thereafter on an ongoing basis.
Wow.
There are also aquaretic side effects like increased urination or polyuria and thirst, which, while generally reversible if the medication is stopped, can be quite bothersome for patients.
Yeah, I can imagine.
And as we discussed earlier, the Mayo imaging classification,
Yeah.
using MRI or CT to determine kidney volume and growth rate
Right.
is really key for identifying appropriate candidates who are most likely to benefit from tolvaptan.
So careful patient selection and adherence to that monitoring schedule are absolutely critical
Absolutely.
if you're considering tolvaptan.
Yeah.
Okay, so what about a more basic and widely applicable recommendation?
Okay.
Increasing water intake in ADPKD patients.
Yeah.
What's the guidance on that?
So the guideline advises encouraging your ADPKD patients to maintain optimal hydration to potentially help minimize the effects of vasopressin,
Okay.
aiming for a urine output of around 2 to 3 liters per day,
Right.
provided their eGFR is 30 milliliters per minute or higher, and
Yeah.
they don't have any medical contraindications.
Right. What kind of contraindications should you be looking out for before recommending increased fluid intake?
So you want to be cautious in patients who have risk factors for fluid retention, such as significant heart failure or cirrhosis,
Okay.
or in those who might be at increased risk of developing hyponatremia or low sodium levels.
Right.
In patients with more advanced CKD, so stage 4 to 5,
Yeah.
or those with any of these contraindications, their fluid intake should be guided by their thirst,
Okay.
or based on individualized clinical advice.
Gotcha.
Plain water is the preferred fluid, and you should advise patients to minimize their intake of sugary or salty drinks and alcohol.
Right.
Caffeine in moderation seems to be acceptable.
So this seems like a relatively simple yet potentially beneficial strategy
Yeah.
for many of our ADPKD patients.
Yeah.
Now let's talk about MTR inhibitors and somatostatin analogs.
Okay.
Two classes of drugs that have been investigated in the context of ADPKD.
Yeah.
So what does the new guideline say about their role?
So the guideline does not recommend the routine use of MTR inhibitors such as everolimus to try and slow down the progression of kidney disease in ADPKD. In fact, some evidence suggests they might even lead to a faster decline in eGFR.
Right.
Similarly, somatostatin analogs are not recommended for the primary purpose of improving eGFR loss in ADPKD.
Yeah.
However, they might have a role to play in managing severe symptoms related to very large polycystic livers, such as significant abdominal fullness or pain.
Right.
If you do consider using them for this specific indication,
Yeah.
you need to closely monitor for potential side effects.
Right.
And the treatment should be stopped if there's no clear benefit observed after about 6 to 12 months.
Okay, so quite specific and limited roles
Yeah.
for those agents in ADPKD management.
Absolutely.
Let's move on to polycystic liver disease, or PLD,
Okay.
which frequently occurs alongside ADPKD.
Yeah.
So what's the nephrologist's role in recognizing and managing TLD in their ADPKD patients?
So when you're reviewing CT or MRI scans that have been done for the kidneys in your ADPKD patients,
Yeah.
you should also take a look at the liver
Right.
to assess the extent of any polycystic liver disease. And you should counsel patients that, liver cysts typically develop a bit later than kidney cysts.
Okay.
And they tend to be more numerous and larger in women, but often they remain asymptomatic throughout life.
Right.
However, if a patient develops symptoms related to a significantly enlarged liver, so hepatomegaly,
Yeah.
further abdominal imaging is warranted.
Okay.
More invasive treatments for PLD are generally best managed in centers with specialized expertise.
Right. And what about complications like infections within the liver cysts?
Yeah, so for suspected liver cyst infections,
Okay.
the guideline recommends using antibiotics that are effective against gram-negative bacteria.
Okay.
You should avoid starting broad-spectrum antibiotics empirically for localized liver pain,
Right.
unless there are also signs of infection like fever, an elevated white blood cell count, and CRP.
Right.
As we discussed earlier, for patients with markedly enlarged and symptomatic PLD,
Yeah.
long-acting somatostatin analogs might be considered. And liver transplantation is really reserved as a last resort for patients with massive PLD that's severely impacting their quality of life,
Right.
causing significant muscle wasting or sarcopenia, or leading to other serious complications, especially if other treatments haven't been successful.
So it sounds like a very individualized approach
Yeah,
to managing PLD based on the severity of symptoms
absolutely.
and potential complications.
Yeah.
Another important extrarenal manifestation of ADPKD to discuss is intracranial aneurysms,
Yes.
or ICAs.
Yeah.
So what are the guidelines around screening for these in your ADPKD patients?
Yeah, so ADPKD is associated with an increased risk of developing ICAs.
Right.
The guidelines suggest screening with MRA or magnetic resonance angiography for individuals with ADPKD who have a family history of either an intracranial aneurysm or a subarachnoid hemorrhage in a first-degree relative,
Okay.
or in 2 or more relatives.
Okay.
You should have a detailed discussion with these patients about the potential risks and benefits of screening and any subsequent treatment options. MRA is preferred over CTA or CT angiography for screening
Okay.
because it involves less radiation and doesn't require intravenous contrast.
Right.
If the initial MRA screen is negative, but the patient's risk factors remain high,
Yeah.
you might consider repeating the screening every 5 to 10 years.
Okay.
Any decisions about treatment, whether to manage conservatively or to repair an aneurysm, should be made in specialized multidisciplinary centers.
So really important guidance for identifying and managing a potentially very serious complication.
Absolutely.
Okay, let's broaden our scope now to consider lifestyle and psychosocial aspects
Okay.
of living with and managing ADPKD.
Yeah. So the guideline emphasizes the importance of a healthy lifestyle.
Right.
And this includes following a nutritious diet consistent with recommendations for overall good health and for chronic kidney disease.
Well,
Plenty of fruits, vegetables, whole grains, limiting processed foods, salt and sugary drinks.
makes sense.
Encouraging a daily water intake of at least 2 liters to aim for a morning urine osmolality below 280 milliosomoles per kilogram is also advised.
Okay.
Sodium intake should be restricted to less than 2 grams per day.
Right.
And patients should aim to maintain a healthy body weight, taking into account that kidney volume can affect BMI calculations.
Yep, of course.
Regular physical activity is encouraged for general health, blood pressure control, and cardiovascular risk reduction.
Yeah.
But patients with very large kidneys or livers should avoid contact sports.
Okay.
Smoking cessation is absolutely critical.
Right.
And alcohol consumption should be limited.
Makes sense.
It's also vital to monitor your ADPKD patients for psychological health issues
Yeah.
and address any social needs they might have, offering education's support programs and connecting them with patient organizations.
Yeah, it really underscores that holistic approach
Yeah.
needed in managing a chronic condition like ADPKD,
Absolutely.
going beyond just the medical treatments.
Yeah.
What about specific considerations for women with ADPKD?
So management in women includes addressing considerations around hormonal therapies, contraception,
Okay.
with caution advised regarding estrogen-based methods in women with moderate to severe polycystic liver disease,
Right.
as well as providing preconception counseling and careful management during pregnancy,
Yeah.
as there's an increased risk of preeclampsia and preterm delivery.
Right.
Close monitoring of blood pressure, kidney function, and specific markers like SFLT1 and PLGF
Okay.
is important during pregnancy in women with ADPKD.
Okay. And what about children who are diagnosed with ADPKD? Are the management principles any different in the pediatric population?
So follow-up in children with ADPKD should be tailored to their individual clinical findings,
Okay.
including blood pressure measurements, kidney function tests, urine analysis, and ultrasound imaging.
Right.
The target blood pressure in hypertensive adolescents is generally lower than in adults.
Okay.
RAS inhibitors are the first-line treatment for high blood pressure in children with ADPKD. Their care should ideally be overseen by a pediatric nephrologist.
Okay.
And a formal plan for transitioning their care to an adult nephrology practice as they get older is essential.
Yeah, that makes sense.
Yeah.
And finally, the guidelines place a strong emphasis on shared decision-making and patient-centered care.
Yeah.
Can you elaborate on why this is so important in ADPKD management?
So shared decision-making is really presented as the cornerstone of optimal ADPKD management.
Okay.
A comprehensive, multidisciplinary, and holistic approach to their care is recommended.
Yeah.
And it's vital to actively involve patients in all aspects of their treatment decisions.
Right.
This includes encouraging them to participate in patient registries and clinical research trials,
Yeah.
educating physicians about the importance of genetic testing,
Yeah.
and ensuring good coordination of care are also key aspects of this patient-centered approach.
Right.
The role of patient organizations in providing valuable information and peer support to individuals living with ADPKD is also strongly highlighted as a way to enhance their overall care and promote disease awareness.
That's great.
Yeah.
So this has been an incredibly thorough and helpful review
Yeah.
of the latest KDIGO guidelines for managing ADPKD.
Yeah.
The key message for nephrologists seems to be the importance of a personalized approach.